Hello. Hello, Hansi.
Hi, Milan. Can you
How
hear
are
me?
you? Yeah, I'm okay. And you?
Good.
Good, good.
Good yourself.
No, I'm good. Thank you. Do you just want to check your screen share?
Okay, sure.
Yeah.
Is that fine?
Yes,
Hi,
Hansi.
Milan. Is that appearing?
That's fine. You will need to just start the slideshow, but I can see the first slide.
Okay, sure. I'll stop sharing now then.
You can stop sharing. Yes, no problem. Yeah. Um, there are still about five,
Milan,
7 minutes.
I'm not sure
Yeah.
if Prof. Shah is going to join us
Okay.
because I did send him the message. He did acknowledge it, but
Yes.
because it's going to be, I think it's going to be a 8:30 in India.
That's correct. Yes, that's correct. And I think
Yeah. So
those people still consult till about 9 o'clock. They consult in the evening.
yes. So that's why initially he agreed.
Yes,
And then when he saw the time, then he just wanted a confirmation of what time it will be.
yes,
So,
yes,
but he was very keen to join us.
yes. But
Thanks, Milan, for inviting me. Can we see the slides?
yes, we can see the slide. Thank you.
All right, sure. Thanks, Milan, for inviting me to present at this webinar. And I think it's been a great success over the past few years, and definitely to expand the knowledge of, apart from the trainees, it's also the the specialists around Africa and from other parts of the world. So I'm going to talk on the current trends in pediatric metabolic and bariatric surgery. And just to start, just to go back to some of the basics, the definitions are it's well defined as to what is underweight and a normal range according to a BMI, overweight, and then obesity. And we can see that once we reach a BMI of above 30, then we fall into 3 different classes of obesity. But if you look at what the CDH has done with regards to classifying children with obesity, it falls into different categories based on the BMI for age, and there's generally a range. So essentially, we're looking at obese above 95% of the BMI for age. And if we then further break that down and look at obesity, then we're looking at the BMI greater than, in class 1, greater than 95th percentile for age and sex. And then class 2 being more than 120% of the 95th percentile. And that's more or less equivalent to a BMI of more than 35. And then class 3 being a BMI greater than or equal to 140% of the 95th percentile. And that's equivalent to or greater than 40, a BMI of 40. So this was one of the reviews done by the WHO, and they looked at the number of children aged between 5 and 19 living with overweight and obesity in 2016, but they also looked at the increase in prevalence from 2010 to 2016. And interestingly, if you see where there's been an increase, it's been in the majority of the developing sort of countries. If you look at Africa itself, there's an increase of about 33%. And if you look at Asia, it sort of ranges between sort of 21 to 48%. So it's interesting that we would think that obesity is predominantly in the developed world, but unfortunately, it's definitely a major problem in the developing world as well. So this was from the World Obesity site, and this looked at the prevalence of overweight and obese adults within the African continent. And you can see that, I mean, there's a wide range of percentages, but if you look at South Africa specifically, you're looking at about a 50% chance of being overweight, and obesity that ranges between 25 and 30%. So definitely affecting almost all the countries that we can see on this graph, with the exception of Ethiopia. So what's the problems with having obesity? And there's a number of comorbidities, and they're defined as cardiometabolic consequences. And the big ones are hypertension, dyslipidemia, type 2 diabetes, non-alcoholic steatohepatitis, obstructive sleep apnea syndrome. And then recently with our current pandemic, it's been noted that in overweight and obese individuals, including adolescents, that there's a chronic low-grade inflammation that's present in these patients. And then the other associated comorbidities will be gastroesophageal reflux disease, and the psychosocial impact of this, benign intracranial hypertension, and then the orthopedic conditions, which we see a lot of, is Blount's disease, and then the slipped capital femoral epiphysis. So just to see what those sort of effects from obesity are having on individuals from around the world, and in this graph that was published in Lancet in 2016, you can see that predominantly individuals or adults with diabetes, and the increased prevalence since 1980 to 2014 have been within Africa. So Central, Southern, and Eastern Africa, and you can see those are the pink lines that run right on the top. So here again, I mean, increasing prevalence of comorbidities secondary to obesity being more prevalent in the developing world than the developed. So this was an interesting slide because it looked at factors that predispose us to developing childhood obesity. And this was published in 2018. And it was based on a number of randomized controlled trials and meta-analyses. And then from looking at all the studies done, these 10 factors predominated. So parental obesity and overweight, then ethnic heritage, excess maternal gestational weight gain, smoking during pregnancy, intrauterine exposure to diabetes, high birth weight, low birth weight but a rapid catch-up, then parental education and income, and this is variable depending on the socioeconomic status, being formula fed, and then having a cesarean section. So when we look at the causes of obesity, I think the biggest group is being idiopathic. That's in the region of 90%, and thought to be secondary to a diet and lack of exercise. But you also have the genetic and hormonal component, and then the Prader-Willi and Bardet-Biedl. So those, and there's a few others that's not listed, but they only comprise about 10% of these patients. And then there's included in that group is the hormonal causes of obesity, and thyroid hormone deficiency, growth hormone, or cortisol excess. And then in addition to that, a very small percentage will comprise the medication related, and that's with the use of glucocorticoids, sodium valproate, and prostogens. So if we look at how we approach the management of bariatric, metabolic and bariatric surgery, or just the general approach, it encompasses a team approach. And This is a list of components that need to, or role players that need to be involved in the management of these patients, which includes a pediatrician, endocrinologist, the surgeons, social worker, psychologist, dietitian, nurse, physio, and exercise physiologist. And if you look at the published guidelines by the American Society of Metabolic and Obesity Surgeons from 2012, and it still stands in the recent publication in 2018, they include, say, specifically an experienced bariatric surgeon, and then a pediatric specialist with an interest, or an endocrinologist, and then they again dietitian, and then the mental health specialist, the psychiatrist. And if you look at setting up this sort of service in South Africa, there's the South African Society of Surgery, Obesity and Metabolism, which aims to achieve centers of excellence for metabolic medicine and surgery. And with regards to the HPCSA, then SASO is the advising body of the HPCSA in South Africa. So management is holistic and encompasses lifestyle, which includes diet and exercise, medical therapies, and then surgical therapies. And then we'll touch on a few of these. So with regards to lifestyle modification, when we look at diets, there's been a few different diets that are used, and essentially a low energy diet. And now there's been talk and implementation of very low energy diets. There's a low carb diet, and then also over the past few years, there's an intermittent energy restriction, or what we know of as intermittent fasting. And then this was looked at last year by Harare, and they looked at these novel dietary interventions for adolescents with obesity. And they found them to be as effective or even better than the previous diets that were recommended. Exercise, the general recommendation is 1 hour per day. And if you look at the different age groups between 5 and 12, and then 12 to 18, then it's recommended that they exercise for a minimum of 3 times per week, but up to about 5 times per week. So Kuderi looked at diet, physical activity, and behavioral interventions for the treatment of overweight and obese adolescents, and this from 12 to 17 years. And this was a Cochrane systematic review. And what they found in this review was that of these interventions, the average weight loss on the individuals were 1.5 kgs. So you can see just from using lifestyle modification alone, not as significant a weight loss as we would expect. So just to expand more on lifestyle modification, this is actually from the Australian New South Wales sort of guidelines. And when they looked or put this together, there were 8 sort of healthy habits that they found to be important and effective in establishing weight loss and maintaining it. And these 8 healthy habits includes drinking sort of water instead of soft drinks, aiming to have 5 servings of vegetables and 2 of fruit every day. Start with a healthy breakfast, be mindful of portions, healthy snacks. Limiting screen time, the recommendation is to limit it to 2 hours per day. However, with COVID and lockdowns and online schooling, that can be a challenge. And what they then recommend is the recreational screen time after the schooling and over the weekends should then be limited. And then activity for at least 1 hour a day. And they recommend being active every day, and then enough sleep. So if we're looking at the lifestyle modifications, so Bauer suggested that or recommended this sort of approach, and which initially means, primary healthcare promotion and prevention as the basis of this pyramid. And then moving on to level 3 care would be sort of 70 to 80% of the patients, and that then encompass self-care support for the families and the doctors, and then group programs. And then if you then are unsuccessful, you then move to a high-risk patient multidisciplinary care. So these are patients who do have comorbidities associated with obesity, and then that still persist with sort of specialized multidisciplinary care teams and programs. And then if you then fall into a more severe category, then you then move into a level 3 sort of complex care, which is specialized obesity clinics and specialist teams. Then you got to ask yourself, where does bariatric surgery fit into this sort of pyramid? And so bariatric surgery will then fall on the apex of this pyramid when we're failing in managing these patients on the other 3 sort of levels. So just to cover some of the medical treatments that were available and are available, and sibutramine was one of them that was withdrawn because of a cardiovascular risk, which predominantly was an appetite suppressant. Orlistat, which is a gastric and pancreatic lipase inhibitor, can be used and normally achieving best results over 3 months with a decrease in BMI of 0.5 to 4 kgs per meter squared. So not a very significant difference. And then metformin is currently used. And recently there was a systematic review and meta-analysis of the randomized controlled trials of the use of metformin for obesity in children. And then there were 38 randomized controlled trials that were found, and overall did decrease BMI, body weight, and then waist circumference. But the average weight loss across all these studies was 2.5 kgs, which is not a significant difference. So we go into the newer modern sort of therapies that's being used. They are the glucagon-like peptide-1 receptor agonists, and the 2 common ones that are available, the one being Saxenda or liraglutide, and then that's normally given as a daily dose, and then the Ozempic as a weekly dose. So generally used for type 2 diabetes with cardiovascular risks, but it is associated with weight loss and has been used for that benefit especially in the patients with obesity and type 2 diabetes. So with regards to the GLP-1 agonists, so there's been a randomized controlled trial for the use of this in adolescents, and this was published in 2020. So 12 to 18 years was the range, and the BMI in this case being just over 30, so falling into obesity category 1. The patients were treated for 56 weeks and then followed up for 26 weeks thereafter, and they gave them a dose that they worked up over a few weeks of 0.62, then eventually 3 milligrams per day. But interestingly, they also included lifestyle modification. And in this study, they found that there was a reduction of BMI of 5% in 43% of the individuals that participated versus a reduction of BMI of 5% in 90% of the patients who just had placebo. So we can see there is definitely some effect over a placebo. And then in last year, this was a B1 agonist in children, so specifically using it for obesity. And there were 9 studies, and however, a modest weight reduction of 0.5 to 2.5 kgs, and but they did find that there was, with the use of GLP-1s, that there was an increased risk of nausea. So just to give you an idea as to what the cost of using GLP-1 agonists can range between sort of like 8 to 12,000 rand for a 1 week duration of therapy. So you can see quite a significant cost associated with this. This was just the forest plots of those 9 studies, and I'm just showing you that the definite benefit with the use of them. So what's the indications for bariatric surgery? So this is clearly defined and published, and the class 2 obesity, and that's more than 120% of the 95th percentile, including comorbidities. So if you have a comorbidity with class 2 obesity, then you qualify for bariatric surgery. And when you look at class 3 obesity, and so that's more than 140%, you don't need to have any other qualify for bariatric surgery. But if you look at the American Society for Metabolic and Bariatric Surgery guidelines from 2018, they do include a few specific things, and one, as we defined before, must manage these patients. And when we look at contraindications, then it has to be those that have a medically correctable cause will be excluded if there's any evidence of substance abuse, and then if you've got a medical, psychiatric, or social issue that prevents adherence to the post-operative dietary and medication regimens. So, and then the other issue is that if you are pregnant or plan to be pregnant, then definitely that's a contraindication to having bariatric surgery. So there's definitely concerns regarding bariatric surgery, and the one big thing that a lot of people are concerned about is the optimal timing of surgery, which is generally unknown. But however, over the years, it's becoming earlier or being done at a younger age, and that's because of the comorbidities. So this publication by Al-Katani in 2016, he looked at laparoscopic sleeve gastrectomies in children younger than 14. So the age range was 9 to 14 years. And then if we look at the second article, that was a sleeve gastrectomy done for a 2.5-year-old morbidly obese child that's currently still alive and well. So the big concerns are growth and maturation, and what essentially is recommended is that you then, if you are going to pursue bariatric surgery, then it should be done on individuals that have achieved physiological maturation, and that's achieving a sexual Tanner stage of 3 or 4, and then skeletal maturity being achieved, and generally in girls between 14 and 15 years, and then boys a little later between 15 and 16 years. But the one, what favors doing bariatric surgery earlier in children is that with obesity is that in overweight children, there's accelerated puberty, and they're often taller with advanced bone age. But objectively, what should be done is assessing bone maturity with an X-ray of the hand and wrist, and that the orthopods generally do, and will be able to give us more information. So if we look specifically at the different types of bariatric surgical procedures that are done, so there's that vertical sleeve gastrectomy, that's in picture B. And then there's the Roux-en-Y gastric bypass. There's the adjustable gastric band, then the intragastric balloon, and biliopancreatic diversion procedures with duodenal switch is not recommended for children because of the major sort of side effects and complications. So we look at the laparoscopic gastric band. Just the basic principle is that it's a band that's then applied onto a bit of the fundus and the cardia of the stomach, and it's a restrictive. So it's based on a restrictive procedure, but it still does require a strict diet. So generally, there's monthly adjustments with sort of by increasing or adjusting that band, you then reduce that sort of volume of the stomach that it's across. And what you can then achieve is excess weight loss of between 40 and 50%. But the complications that can occur with this sort of surgery is the iron and vitamin deficiencies. You can have a gastric perforation. The band can slip, and you can have a hiatal hernia, have reflux, and then accessing the port can be a problem. And then the other thing is cheating. So with regards to cheating, it's so what it is basically having a high caloric sort of intake, but not as a large volume. So if you melt a slab of chocolate and you drink it, it will fit within that sort of 30 to 50 ml space of your stomach. And so people tend to do that. So the vertical sleeve gastrectomy is has been shown to become the preferred method in both children and adults. And here, basically, the principles involve using 32 to 34 French bougie, and you then staple the stomach from about between 5 and 6 centimeters from the pylorus to the angle of his. And this is a restrictive procedure, but by getting rid of the fundus, you then induce satiety by reducing the amount of ghrelin and protein Y. So in pediatrics, there's specific benefits for pediatric patients, because in patients that have vertical sleeve gastrectomies in adults, there's increased risk for alcohol addiction, but this doesn't occur in children. And the other issues is there's reduced vitamin deficiencies associated with this procedure and a decreased reoperation rate as compared to a Roux-en-Y gastric bypass. And these can be done laparoscopically, but there are complications. You can still have vitamin deficiencies, leaks from that stomach line, which is often oversewn by some surgeons. They can be bleeding from that suture line or staple line, but however, there's a less obstructive incidence of obstruction. And then in some reviews, it's been associated with high incidence of reflux, but we'll touch on it. But yeah, you can achieve excessive weight loss of more than 50% over 3 to 5 years. And then the downside to this, it's a non-reversible procedure. So just to expand a bit on reflux in patients with obesity. So we know it's associated with obesity. But the issues are that if you had a previous swan application, then it does increase the surgical risk and the complications of some sort of, or of any of the sort of procedures that involve the stomach. And so generally, so previously it was recommended that a Roux-en-Y gastric bypass be done. But what's been found with vertical sleeve gastrectomies is that the risk of developing GORD is variable, but as the weight loss increases, there's a reduction in the incidence of GORD. So vertical sleeve gastrectomies are not entirely, or not anymore, a contraindication to in patients with gastroesophageal reflux. So with the Roux-en-Y gastric bypass, the principle is that it's restrictive because you're creating a small pouch and a small outlet. And the malabsorptive component can be variable, and you can do a standard length of 75 centimeters, a long limb of 150 or a very long limb of 250, which then have different outcomes. And what essentially it is rerouting food. And so then you get changes in your gut hormones, which then promote satiety, suppress hunger, and been shown to reverse the type 2 diabetes. But the complications include the malnutrition, the deficiencies, gastrointestinal obstruction, and often associated with internal herniation, marginal ulceration, and then the development of gallstones. But the excess weight loss is a bit higher than compared to vertical sleeve gastrectomies. And in the long term, we're looking at 60 to 80%. So if we look at outcomes, specifically, we want to know, does the procedures reverse the comorbidities? And across the board, there's definitely improvement in the blood pressures and hypertension, the diabetes, insulin resistance, cholesterol levels, obstructive sleep apnea. So all of those. And so we'll go through a few of the publications that's come out. And this is one of the older ones. It was from 2014, and this was the effectiveness and risk of bariatric surgery, and this was a systematic review and meta-analysis. So in this sort of group, it was of adults, but we're looking at 161,000 patients that Roux-en-Y gastric bypass and sleeve gastrectomies, and they had a BMI loss of, on average, between 15 and 16 kgs per meter squares at 5 years. The 30-day mortality was minimal, but there was definitely resolution of the diabetes, hypertension, dyslipidemia, and the obstructive sleep apnea. And if you look at that, I mean, you between 75 and 96%. So major differences in those comorbidities. So this was published by Black and looked at bariatric surgery for obese children and adolescents. Here again, systematic review and meta-analysis from 2013. Here, a total of 637 patients from 23 studies. Here, it included a laparoscopic adjustable gastric band. And here, there also a BMI change of, on average, 13.5 kgs per square meters. And if we looked at the group, the Roux-en-Y gastric bypass at 1 year, that group specifically had a change or decrease in BMI of 17.2. So Al-Qahtani looked at the outcomes of doing laparoscopic sleeve gastrectomies in adults and children. And he published this in 2012. This was just a 3-year review. It was a retrospective review of 108 pediatric patients, which had, this was done in a mean age of 13.9, but the excess weight loss being 65% in children and in adults of 69%. But there was definitely a higher BMI change in the pediatric group. So, or the presenting group, sorry, was of a higher BMI. Then he looked at comorbidity resolution as a result of those sleeve gastrectomies and the outcomes in 226 adolescent patients. And what he found that they had shown, there was a normal sort of growth velocity despite a third of the patients under 12 years. And then he went on to do a 10-year outcome of children and adolescents who had sleeve gastrectomies. And then he looked at weight loss, comorbidity resolution, and adverse events and growth velocity. So by this time, this was published last year. He had done 2,000, in excess of 2,500 cases, and the age range was between 5 and 21 years. And you can see, so obviously, when looking at considering the concerns, so El-Qahtani has definitely challenged a lot of the concerns with regards to when we're doing bariatric surgery and the outcomes. So all had laparoscopic sleeve gastrectomies. So the excess weight loss at the patients at 10 years remained at 71%. And what he noted in those children who were done, whether it was at 5 or at 12 or 16 years, was that there was no significant change in the growth velocity over the period of observation. So there's been other big sort of reviews and that are well published now. The one is the AMOS study, adolescent morbid obesity surgery study. And from this group, they did laparoscopic Roux-en-Y bypasses and in the severely obese patients, and they looked at a prospective 5-year review. And they had 81 patients with the average age of 16 years, and the average reduction of BMI was 13 kgs. But significantly, the risk factor resolution ranged between 74 and the cardiovascular risk factors were resolved in 74 to 100% of these patients. And when they compared to control adolescents, what they found was in some of the control patients, the BMI increased during the study, and 25% of the controlled group then eventually had surgery. And just an expansion on AMOS 1 is AMOS 2, and that's currently ongoing from 2017. And they're looking at the long-term outcomes of metabolic bariatric surgery versus lifestyle modification. There was a recruitment of about 50 patients, 25 in each group. And then they're following them up in intervals of 2, 5, 10, 15, and 17 years post-intervention. So it'll be interesting to see what the outcomes are in that comparative study. So if you look at the other big group, that's from America, and that's the Teen Labs group, and they call, well, the Teen Longitudinal Assessment of Bariatric Surgery. And there's been a few publications from that group. So they looked at periodic outcomes of adolescents undergoing bariatric surgery. And this was the largest prospective multi-center observational study in adolescents to measure safety and efficacy of weight loss interventions. So 242 cases over 3 years. Excess weight loss with the Roux-en-Y gastric bypass was 28%, and then with sleeve gastrectomies, 26%. But here again, the remission of comorbidities was amazing. I mean, between sort of 66% and 95% for the diabetes. So this was also another publication from them, which had looked at the long-term outcomes. And this was also prospective for Roux-en-Y gastric bypass after 8 years. And the long-term BMI reduction was then 29% in this sort of group of patients. But they noted a few deficiencies in this group of patients. And you can see anemia, hyperparathyroidism, and then the low amounts of vitamin B12. And then the big issue over the long term is compliance, because obviously these kids need regular follow-up and supplementation of vitamins and minerals. And then Matt Booley looked at a 5-year follow-up study of laparoscopic sleeve gastrectomies. And what he was looking at, does it improve body image and prevent and treat diabetes? Here again, excess weight loss, 78% at 5 years, and a 75% cure for the diabetes. So Inge also looked at the 5-year outcomes of gastric bypass as compared to adults, and what they wanted to see, what was their difference. So what they found was that the weight loss between the adults and the adolescents were similar, but the remission of diabetes and hypertension was greater in the adolescent group compared to the adults. And we know that if you treat and resolve your diabetes and hypertension during the adolescent phases, then you're not going to carry that into adulthood. So in 2018, then Inge also conducted a collaborative study, and they compared the effectiveness of bariatric procedures among adolescents. And this was over a period of 10 years, from 2005 to 2015. And then they looked at Roux-en-Y gastric bypass, sleeve gastrectomies, and then gastric bands. And what they found was that there was greater reduction in BMI for sleeve gastrectomies and Roux-en-Y gastric bypass after 3 years, when then compared to the gastric bands. So just to move on to the genetic types of obesity, and generally a contraindication to bariatric surgery. But this was an interesting review that looked at clinical approach and current trends in 2016 and was published. And you can see that, so Prader-Willi, for example, there's been a number of publications of patients who then underwent bariatric surgery and didn't suffer any major sort of complications, but managed to achieve excess weight loss. And then Bardet-Biedl as well. So there's been, well, isolated case reports in the other groups without any sort of complication. So obviously people are pushing the boundaries and in treating these children, but and with some success. So I just wanted to touch on a few novel techniques, and I did mention this intragastric balloon. And with regards to the intragastric balloons, obviously it's restrictive because you're reducing the volume of your stomach. There's a few different types that are better. That's a single balloon, then Reshape that has 2 balloons that's generally filled with saline. Of Reshape, there was one publication of a perforation as a complication, and the Obolon that has 3 balloons and can be swallowed. The other 2 needs to be inserted using a G-scope. But however, it still has to be sort of used in conjunction with lifestyle modification and generally removed after about 6 months. And then this review from 2017 looked at the efficacy of this gastric balloon treatment in adolescents. And they had a small number of patients, but ranged between 40 and 19 years. But they had achieved excess weight loss of 56%. The only question is this sustainable over the long term and once you've removed that balloon? And then Endobarrier is a sleeve that's then endoscopically placed, and then it prevents mixing of food. And here as well, achieving results of excess weight loss of between 11 to 26% over a 6-month period. So Patel then looked at this novel sort of technique, and over 12 months, 45 candidates, apparently 14 of them withdrew. They don't tell us why, but had BMI reductions of 4.9, so which is not as significant as compared to the other established bariatric surgical procedures. So I just wanted to conclude to say that there's definitely increasing prevalence, especially amongst the developing countries. And it's been shown that adolescent bariatric surgery is definitely superior to dietary intervention and lifestyle modification. So with achieving sort of sustained weight loss in excess of 30%. And the big benefit is the resolution of the comorbidities in these children and having them alive. But you do have long-term concerns with vitamin and mineral deficiencies, and there's a possibility of reoperations. But I think in managing these children, it has to be a multidisciplinary specialist team approach going forward. I just wanted to say that we all pray for the victims of the KZN floods that occurred over the past week. Thank you.
Thank you very much, Hansi. It was an excellent, well-studied talk with all the scientific evidence. I think it's really an example for the trainees how a talk should be prepared and how it should be presented. And I'm really glad that at the end of the talk you mentioned about the terrible disaster which we are facing in KwaZulu-Natal, and all our prayers are with our colleagues and the rest of the community in KZN. I have two queries which you can read and answer them, and then George Knock, I think he is in Kenya if I'm correct. He has also one query, so maybe you can answer those queries, and then I will request experts to comment.
Okay, thanks, man. So George Knock was asking, at what point do we say that non-surgical treatment has failed and that will then require surgery? So thanks for the question, George. And but just to go back to the indications, and so it depends on where we see the patient. So if you have a patient that presents to you with grade 3 obesity and a BMI of greater than 40 and comorbidities, then there's no doubt as to where you start. So you're going to start with bariatric surgery. But if you have a patient that's just overweight, then we should start with looking at the lifestyle modification and then trying to establish some sort of excess weight loss based on that. So if you look at all the reviews, and I can't talk on personal experience because we don't have an established center, but it's going to be long-term review. So these patients, if you look at the Australian group, the recommendation is to see these patients 20 times over a 6-month period. So for you to get, firstly, develop, establish a rapport with the patient, and then get them to be adherent to the sort of recommendations of lifestyle modification, those 8 healthy habits, and making changes. But it also has to be a family approach. It can't be an individual. So if you look at establishing those lifestyle changes, then you need to involve the entire family, and all of them need to be part of these changes as compared to just the child in that household. So I hope I've answered your question, but so it'll depend on where the child fits in on the categories of obesity and overweight, and then depending on that, the interventions that will be implemented. And if you're failing, then obviously, or there's worsening of the condition and the child's developing comorbidities, then you then proceed to the next step of care. So I'm just going to respond to Milan's question. Do the children have to continue diet and lifestyle modifications after bariatric surgery? So generally, there are protocols as to how it needs to be approached, and it definitely has to include a strict diet and lifestyle modifications. And when you look at post-bariatric surgical feeding, there are protocols as to how it should be approached. And so high protein diet with initially small volumes and increasing that over time to an established volume where you're maintaining your nutritional status without taking too much of calories. And then based on that, together with that, it's a strict follow-up and monitoring of your vitamins and your electrolyte deficiencies and your hemoglobin. And then does the excess weight loss mean they've lost that much weight as compared to starting weight? So if we look at excess weight loss, it's compared to what should be the ideal weight. And we're looking at the upper limit of the ideal weight based on those graphs for the age and weight and height, sorry. So if we're looking at the BMI charts, then we're looking at what's the upper limit of the ideal weight based on those charts. And then the excess weight will be over and above that. Thanks. I hope I've answered those questions.
Thank you, Hansi. I saw Prof. Sheikh was here, but I think probably it is time to break the fast, so he must have left. I see Dr. Majola is still here. Dr. Majola is a pediatric surgeon in Port Elizabeth. Dr. Majola, any comments, any questions to Dr. Mangray?
Hi, Prof. Thanks, Hansi, for just a great talk. He has kind of answered my question, because I was going to ask more of where do we basically then decide as to when to intervene surgically, because I know with adult surgery, they always sort of start with lifestyle modification, and they need to make sure that the individual is following some sort of lifestyle, and they are actually starting to lose weight before they intervene surgically. But obviously that's with if they're not struggling too much with the comorbidities that are causing them a problem. But yeah, that's basically all I have to say. Thank you.
Thank you very much.
Milind, I'll just add to that.
Yes, please.
So in most of the recommendations, then they would still do so. Even if you're presenting upfront and require bariatric surgery, you'll still have a 6-month window in which they will then assess the, the psychological component and the compliance, and they will be put on a energy restrictive diet. So everyone will get a minimum of 6 months under supervision, under the team, and then they will then proceed to the management.
I just want to ask Dr. Nakolo Mashawawe, who is our junior consultant, recently joined our team. Dr. Mashawawe, any experience? Have you assisted any bariatric surgery in Johannesburg?
Good evening, everyone. Thank you, Mr. Mangray, for the wonderful talk. No, we actually didn't do any bariatric surgery in Wits. Yeah.
Okay, Noxie, thank you. I see Abby Rosenstrauss is here. She is a dietitian. So maybe a comment from dietitian. Abby, you can just unmute yourself and make a comment.
Thanks, Prof. No, nothing really. I think just, yeah, probably about the importance of obviously adhering after the surgery, should it need to be done. Because I know I have heard of patients and people thinking that it's just sort of a quick fix, the surgery, and that then they can go back to, any sort of lifestyle. But yeah, I don't have any experience, unfortunately, with this. Yeah. Thank you.
Thank you, Abby. Yeah, this is quite an advanced field, but I think the need is going to be more and more, with 50% of adult women and 30% of our children falling into the category of obesity. And as Dr. Mangray said, as more and more of them are going to be diagnosed with comorbidities, I think this surgery is going to become more and more necessity. Hansi, final comments from you before we close?
Yeah, so, we were looking at establishing a unit here in KZN, and I think that's what needs to be done in, all the big centers in South Africa. And that's, so where we need to start is to put a team together. And unfortunately, we were doing this just before COVID hit, and so it's sort of still lagging behind. But once you can establish a team, then you can get sort of regular follow-up for these patients. And the patients are there. I can tell you, I mean, we have from the pediatric orthopedic group that's in KZN, they see with Blount's disease on its own, I think there's a collection of about 150 to 200 patients. And the big component of them, or the biggest risk factor, is obesity. Then from the ENT group and all the kids with obstructive sleep apnea, there's a large proportion that are overweight and obese. And so often we do get consulted about these children, and even from the endocrinologists. But until we can start to establish some sort of multidisciplinary team, and I know we have limited resources, and then even just start with the lifestyle modification. So get to some point where we can start to make some changes and have regular follow-up for these patients. I think that's where we need to start this, and then take it forward. I think the surgical part of this is not complicated, but obviously you do need to have proctors and be supervised. But I don't think it's as difficult. But I think the big issue is the adherence to the therapies that's proposed and establishing the supporting therapies so that we can then move forward to that, to establishing, bariatric surgical centers. But thanks, Milind, for the interactive talk and all the great questions.
No, Ansi, thank you. I think I'm very glad that you are establishing a sort of pediatric obesity clinic in Maritzburg. Obviously, I'm sure it will be part of the adult clinic. And we will try and send one of our consultants to you when you are planning to do one or two of these operations, so that they will also become familiar with the surgical procedure. But obviously, we'll have to have a team established here before we contemplate any surgery like this. So Hansi, thank you again. It was an excellent talk, and as I had anticipated, our wish was fulfilled of getting a scholarly talk on childhood obesity surgery. And thank you for all the attending. We are certainly having colleagues attending from West Indies, and there was a colleague attending from Singapore. So I'm sure we are doing something good. In a month's time, on the second Tuesday of May, at same time, we will have a talk by another very experienced pediatric endoscopic surgeon, Dr. Rasik Shah from Mumbai in India, and he will be talking about vesico-ureteric reflux. So we will see you in a month's time. Thank you, everyone. Have a good evening.
Thank
Bye.
you.
Bye.